Professor Jag Singh is Jagmeet to me, was born in Delhi, and then went around quite a few places in the country for his medical education as well as his postgraduate studies. He's an alumni of BJ Medical College, Pune, from where he got his MBBS and MD in medicine. Then came to Mumbai and did his DM cardiology at the Department of Cardiology at the KEM Hospital. Then he got P.N. Scholarship, which took him to Oxford, where he worked in electrophysiology, and then moved on to Massachusetts and was a part of Framingham Heart Study. Thereafter, he did his training in medicine, cardiology, and cardiac electrophysiology at the Mass General Hospital, Boston. And eventually, he joined as a staff at the Mass General in 2003. To his credit, he became a clinical director and Roman W. DeSanctis Endowed Chair in the Department of Cardiology at Mass General from 2015 to 2020, and is founding director of resynchronization and advanced cardiac therapeutics at the Mass General. And of course, is a professor of medicine and cardiology at the Harvard Medical School. On a personal front, I think he has been, as I remember, in late 80s and early 90s, very focused, very hardworking, scientifically honest, and above all, very humble. He has to be bright to reach places like he has already reached. And lastly, he's a great friend to have. Whenever I have knocked at his door, I have yet to hear a no. For everything, he's always there. So without standing between you and him, I hand over the podium to Professor Jagmeet Singh. Over to you, Jagmeet.
Excellent. Thank you. This is an absolute pleasure and a privilege to be here. Appreciate all of you taking the time to be here. I want to thank Dr. Rawat. I want to thank the chairpersons, Dr. Mahajan, Dr. Dalvi, and Dr. Kerker for being here and for chairing this session. I want to thank you all for taking the time to be here, and really, really do appreciate that. I want to take a moment also to thank Dr. Sanjay Bindra for kind of helping orchestrate this through the GOSUMEC. It's a rare honor to kind of come full circle back to the place that you trained. I spent a couple of years here training in cardiology, and I sincerely tell you that it is created and constructed the backbone of my clinical trajectory over the rest of my life till now. What I learned out here was phenomenal, and the mentorship I got from Bharat, Praful, Yash, and my colleague Amit, who have continually inspired me, has been just remarkable. And I continue to try to do things because I oftentimes ask myself, what would Bharat do in this particular situation? So I really appreciate that. And it's been a phenomenal journey, and I hope to share a part of this with you. So thank you again. My objectives today are really fairly simple. I will talk about AI, but what I want to really talk about is really illustrate some of the gaps in our healthcare system, talk about the role of sensors, where that becomes a part of how we look after patients, talk a little bit about AI and how it integrates with sensors, and then talk about what the potential future models of care can look like in modern medicine. Some of this may sound conjecture, but I think much of this is non-dystopian. This is all a tangible technology I'm going to talk about, and it's just around the corner, if not a few years away at the most. So let me start with a saying from a really famous American writer and a futurist, Alvin Toffler, who said that change is not merely necessary to life, it is life. And I'm guessing this resonates with everyone out here, because all of us have experienced change on a continual basis, whether it's socially, whether it's culturally, whether it's geopolitically, whether it's environmentally. And medicine, too, is going through this transition. There is this metamorphosis, this burgeoning metamorphosis and this digital transformation that is occurring that is going to change the way in which we receive and we deliver care to our patients. And much of what I'm going to talk about today is related to that. But let me just just repeat to some extent what Bharat said very quickly, is that I trained originally in BJ Medical, came down, did my cardiology here at KEM, went on a scholarship to Oxford, did some clinical electrophysiology and research, did my PhD there, my doctorate out there, went to the Framingham Heart Study, and then subsequently came to Mass General Hospital, and I became faculty in 2003. Now, the reason I'm pointing out this is I want you to know that I had this opportunity of working in 3 healthcare systems. One of them, which I may say, to some extent, ours within India, is poorly resourced, right? One within the UK is resource constrained. One within the US is well resourced, but the problem is that none of them really work very well. I think all of them are broken in some form or fashion. We do the best we can, but they're not optimal. And I say they're not optimal for a variety of reasons, and I'm not going to delve into them, but one is that we as clinicians, me, myself, are so vested in the status quo that we want to practice medicine the way we've learned it, and we don't want to shift from becoming uncomfortable in the way we practice medicine. So that's one. Second is resources are always a problem, but along with that, there's always political will. Can we really make this happen? Do we want to make this happen? And there are so many different priorities that people have that oftentimes the leadership and the political will is lacking to make some of these changes happen. But I think what more importantly, it's broken because we have some concerns with the way the system works right now. And the system in all 3 countries, I would say, is inefficient, is inept to some extent, but highly inequitable, right? We look at the disenfranchised people who are being treated in public hospitals versus those in private hospitals. The system by itself is very inequitable. And a living contradiction. We talk about value-based care and looking after our patients, but we practice, at least in private practice, we practice volume-based care. We're trying to do high revenue cases, generate high margins. So there's this dichotomy in what we say and how we behave. Now, beyond that also, I think it's important to recognize that in the United States, for sure, I think everybody knows that 20% of the GDP in the US goes towards healthcare. That is $5 trillion, okay? That's more than the economy of any developed nation in Europe. Despite that, within that $5 trillion, 3 of every $4 goes towards looking after chronic diseases. And I'm going to full circle back on that chronic diseases component out there. But what I want to say is we're a living contradiction because the wellness of our system, the wellness of our organizations, the wellness of our healthcare system depends on the sickness of our patients, right? And that's the argument we need to kind of flip across. How can we flip that argument where the wellness of our organizations depends on the wellness of our patients? And that's something I'm hoping that over the course of the next few minutes, I can kind of elaborate on that. I'm going to try to do this with a single story out here, which I'm going to take you through. And this is about Paul. For all practical purposes, he could be Prem, he could be Pradeep, he could be Purushottam, or could be Priyanka. So let's presume this is Paul's story. This is a real patient that I had. I met Paul for the first time in 2003 when I had just graduated from my electrophysiology fellowship and I was a newly minted cardiac electrophysiologist, right? Paul, at that point in time, was 71 years old. He had chronic diseases. He had diabetes, he had hypertension, he had hyperlipidemia, he had chronic kidney disease. He actually had end-stage renal failure and was on hemodialysis for 7 years before I saw him. Now, why did I see him as a cardiologist? He was referred to me because he had heart failure. He was NYHA class 3 to 4 almost at that point in time. Was very short of breath, even walking to the bathroom. And as you may recall, it was in 2002, December, that a therapy called cardiac resynchronization therapy that just got accepted, was FDA approved in 2002, December. 2003 is when I saw him, and at that point in time, if you look at his EKG, the echo is not playing. Okay, well, one of the videos I had out here are not playing, but that's okay. Let me go up a little bit. There it is, okay. Yep, it's playing out there. If you can, I can see it out here, but you can't see it there, but that's all right, doesn't matter. What you are going to see basically is a heart that has an ejection fraction of 15%, okay? And it's wobbling on itself, and there's a wide QRS out there suggesting that there's electromechanical dyssynchrony out there. And what I was going to tell you is that this patient developed heart failure and developed kidney failure because things went wrong. He had these chronic diseases that were not looked after, and these chronic diseases progressed to the extent that he actually landed up having severe heart failure. And at that point in time, CRT was available, and I was told by my seniors, my senior colleagues, that don't go anywhere close to implanting a device in him because his 1-year mortality is almost 100%, and his 1-month mortality was almost 90%. The chances of him surviving were not there. Much to their chagrin, I decided to go ahead and implant a device in this patient, and I implanted CRT in this patient. And I'll tell you about his story later on, but he started doing a little better. His ejection fraction, which was 15%, now became almost about 30%, okay? And I'll come back to his story in a little bit. Now, what I want to again emphasize out here, that the main story in medicine for us is not making a diagnosis of disease, right? For us, maybe it is, but for the patient, it's about finding a tenable life with that disease process. For a patient who has heart failure and kidney failure, they're trying to think every day, how are they going to live their lives with that particular disease? And that's really important for us to understand. Whereas for us, we find ourselves as clinicians pulled in 5 different directions, and we find that in the workings of a busy hospital, we find it very difficult to be able to truly meet the expectations of our patients. I mean, you look at it in the outpatient area, the way we see patients one after another, we're not able to connect, not able to spend time. But now I think times are potentially changing, and that's what this talk is essentially about. We are blessed with unlimited connectivity. We're blessed with ubiquitous data. We are blessed with the massive processing power that computers give us now. And this provides us with the opportunity of changing the way how we look after patients. So if there's a message I can leave you with today, the single message is that the future of care will be virtual, at least partially virtual. I think we experienced it in our COVID times, and we found that it works pretty well, but it doesn't work well in all circumstances. So it'll be partially virtual. It will be sensor-aided. It will be powered by predictive analytics and artificial intelligence, but it will need to have sustainable workflows that can be integrated into clinical practice and that can translate into better clinical outcomes, right? That's the holy grail, that's the equation, and that's the equation we have to fulfill over the ensuing years to make sure that the future of care really translates into better clinical outcomes. So let me break this down. I'm going to break this down very simply. I think all of us recognize this wonderful saying from Immanuel Kant that all knowledge starts with our senses, right? Our senses, we know the 5 senses we have, our smell, our sight, our touch, and our taste. All this provides knowledge. This knowledge goes to our central general processing unit, which is our brain, which again we know can be completely digitized. And that information then goes through this sensory network to the rest of the body and provides us this analog experience. But this analog experience of each of these senses can be broken down into electrical charges. And we don't think about this from that perspective on a daily basis. But every cell, every organ operates through a sequence of binary codes. Surprise, surprise, right? As a result of which, it is quite possible that we can digitize the entire human body and create digital dashboards, almost creating an automobile equivalent of the check engine light. And this can provide us the opportunity of not only monitoring, but even forecasting, and eventually proactively intervening in disease. And you can see out here, almost every organ system now has sensor-based approaches that can quantify the function of an organ. Many of them investigational, but many of them actually are finding their way into clinical practice as we speak, but still yet to find their way into suitable workflows and still needing to be validated as we move along. Now, I know the electrophysiologists out here, Dr. Lokanwala and Dr. Vora will for sure recognize that we've been implanting devices in patients for many years. These devices, whether they're pacemaker devices, ICDs, or CRTs, are connected to the heart, but they carry a variety of sensors out there. These sensors can measure heart rate and its derivatives. They have accelerometers that can measure physical activity. They have impedance-derived measures. They can measure heart sounds. They can measure respiratory rate. They can measure tidal volume. And besides that, there are a slew of sophisticated sensors that can measure pressure inside the heart. And even now, there are certain biomarkers that can be assessed by implantable sensors in the body. And I'll talk about this a little more. But not everybody has a classic pacemaker or an implantable devices. But in those situations, there are situations now that you can actually implant standalone implantable sensors. And many of us already implant implantable loop recorders. These loop recorders contain all the sensors that I just talked about. There are sensors in the right atrial lead that can actually measure cardiac contractility, measure cardiac output, and they can rechange the programming within a device. There are sensors that can be implanted in the pulmonary artery that measure the pulmonary artery diastolic pressure, and this can help us manage patients' cardiac output and their heart function. There are sensors that can be implanted in the left atrium, and you can see on the extreme left out there, this is a study that we conducted and ran called the Laptop HF study, where you could put a sensor in the interatrial septum that could then be measured with a handheld device, and you could tell, the patient could tell what their pressure in their left atrium is and adjust their medications accordingly. Now, this study was closed a little early because of safety signals, which I'm happy to answer later on, but you get the point. The fact is that the entire cardiac vasculature in many forms, at least the contractility and its function, can be eventually digitized. Now, these sensors, I got interested in sensors somewhere in 2009 or so and started doing a fair amount of work in trying to risk stratify patients, finding out which patients go on to actually develop disease. And this eventually, if you look at it, it's a narrow form of artificial intelligence. If the device within, if you look at nocturnal heart rate variability, look at physical activity, you can actually stratify which patients are going to die in 1 year versus which patients are going to survive. These are small little coded and algorithms that can be generated, which are a narrow form of AI. Besides that, you have sensors now that can actually look at pressures and decide which patients are going to develop cardiac failure. There are sensors within the devices now that can actually automatically reprogram the device depending on cardiac contractility. And then more and beyond that, there are integrated sensors now within these devices that look at heart sounds, posture, respiratory rate, transthoracic impedance. They create an integrated blended sensor assessment of what the cardiac status is and actually can predict which patients develop heart failure 30 days before they actually develop heart failure. Now, if you can predict heart failure 30 days before it actually develops, you can prevent heart failure hospitalizations, and I'll tell you why that's important. And these are things that are available, not necessarily integrated into the clinical workflow as yet, and we can talk about that. But it's important to recognize that some of these are available. But then the question you may bring up to me is that not everybody has an implantable device, and not everybody is interested in an implantable device. But there are now considerable number, almost about 500 different wearable sensors that are available. And by the end of this talk, there may be another 50 that are available. So these sensors can actually be put on your earbuds, can be put on your necklaces, they can put on your cufflinks, they can be around your belt, they can be vests. They all measure different parameters of your cardiac and heart function and other parameters like sweat. There are sensors now that can be tattooed. There are smart sensors that are actually actively being tested right now that change color based on your blood glucose level or change color based on your body pH and electrolytes. So there are actively sensors out there that can monitor your different clinical situations. And then there are the continuous glucose monitors. I think we all know that diabetes can now be monitored by the Dexcom and by the Freestyle Libre, which can, there are also sensors that I'll show you that can measure the NT-proBNP on a daily basis that can help patients manage their own heart failure status. And then obviously there are ambient sensors. There are sensors that are present on toilet seats that can measure your weight, record your ECG, assess your microbiome, and provide an in-depth analysis of what your clinical status is. These are validated, some of these, and are finding their way into practice as we speak. And there are obviously ambient sensors that can measure gait and stability that already a lot of the elderly homes have those to prevent falls in many of these patients. Now, alongside this, and I'm not going to spend any time on this, is the smartphone. And there's such a lot of functionality in the smartphone that exists now. And we know that, it's ubiquitous. About 85% of the folks in the US, adults, have smartphones, almost 90% now. And across the world, about 70 to 75% of people, adults, have smartphones. It gives you an idea, the potential of sensor-based strategies and AI-based strategies getting disseminated and providing an opportunity of creating health and global health equity, and I'll come to this in a little later. Now, these phones, besides this, also provide the opportunity of actually phenotyping patients. So, we talk to psychiatrists at Mass General, and they say that, phones, by the number of times patients pick up phones, the time they spend on their phones, what time of the day they pick up the phones, their clinical behavior can be phenotyped, whether they're different types of depression, bipolar disorders now can be phenotyped by phone usage. And somebody once told me that, patients may lie, but phones don't. They truly represent who you are, right? So having said that, phones also allow us now to monitor hypertension, monitor diabetes, monitor atrial fibrillation, monitor heart failure, and I'll talk about that. But the important thing is, these are the same conditions that Paul had, that we just talked about. Now, Paul started doing pretty well. His heart function actually from 15% went up to 45%. He was still very brittle. He was on hemodialysis, had multiple admissions because he had atrial fibrillation, and he also had non-sustained ventricular tachycardia, and he had short runs of ventricular tachycardia for which we had put him on medications. But the fact of the matter was that at that point in time, we're talking 2003, 2005, there were no sensor strategies available to look after Paul and to monitor him very carefully. Even though he had an implanted device, it was well before sensors and remote monitoring became a part of the equation of providing care to these patients. I'm going to digress out here. If you remember, I told you the part of the equation is virtual care, sensors, AI, and sustainable workflows. So we talked a little bit about sensors. Let me just backtrack into virtual care. So when COVID hit us in the US and hit here in India at the same time, one of the first things we decided to study, and the study that I was kind of initiated, was are everybody really able to access virtual care the way we think they can? And lo and behold, we found that actually there was a fair amount of variability in access to video-based care. And much of the patients who did not get video-based care either had public insurance for Black patients or Hispanic patients. They were the disenfranchised patients with low household incomes. And uniformly, most of these patients were the ones who had heart failure and were elderly patients. Now, I say that is because most heart failure patients are usually disenfranchised patients because they're not doing well and they have all these covariates and risk factors. But the important thing I want to really point out is, in 2006, I had started one of the first multidisciplinary clinics, I think, in the United States, which was a multidisciplinary clinic for patients with heart failure and implanted devices, where we actually saw patients together with the heart failure doc, the EP doc, the echocardiographer, as well as the device tech and a nurse practitioner. We had combined meetings providing integrated care at one stop. COVID actually told us that you can do this virtually. You can actually bring all the disciplines and provide the best integrated care because it's so challenging to bring specialists all together. But now we actually were able to bring patients in, and especially the heart failure patients in, and you can see us four out there alongside my heart failure colleague, the patient is there, and my nurse practitioner is there. And we were able to share all the device diagnostic and device parameters pulled out from the devices with the patients. So one thing I want to tell you is, if the future of care is going to be virtual, a significant part of that also will be multidisciplinary, whether it's cancer, whether it's heart failure. One of the best ways of providing the most individualized care is going to be using multidisciplinary care. Now, everybody knows about heart failure. It's a big problem in the US. It's even a bigger problem out here. The projected expenditure is about $70 billion by 2030. When I was clinical chief of cardiology, I had constructed many rapid response teams, and I used to spend every morning with the heart failure team going through the data about how many patients are admitted with heart failure and how can we prevent readmissions. We're a relatively small hospital by Indian standards, but a big hospital by US standards. Mass General Hospital, we have about 1,000 beds. Within those 1,000 beds, at any given time, cross-sectionally, 120 patients admitted at Mass General Hospital have a diagnosis of heart failure. Just gives you an idea how much of a problem it is and how multivariate, how many covariates can actually influence how patients do. The reason I'm pointing that out is that now every readmission, that patients have is associated with a further decline in clinical status. They never really bounce back exactly back to where they started. And that decline eventually results in pump failure. And one of the ways we can prevent that decline and readmissions is through the use of these sensor-based strategies that we just talked about, in addition to the virtual-based approaches that we also touched upon. Now, this is a slide I generated in 2010. So it's still, now it's become relevant. It was way ahead of its time in 2010. And one of the things I used to think about patients with heart failure, when they develop acute heart failure, there's a lot of things along the path that actually influence that. One of the things, the patients who develop heart failure have an abnormal neurohormonal status. So now there are sensors that can measure the sympathovagal balance and the neurohormonal status that you could not before. All these patients with heart failure have comorbidities, could be hypertension, diabetes, COPD. Now you have sensor-based strategies that can actually measure this. We just talked about diabetes and hypertension. And you also have triggers such as arrhythmias, and now we have sensor-based approaches, patch monitor-based approaches that can monitor these patients who develop arrhythmias that lead to patients developing heart failure. And we have watches now, and there are a slew of parameters that I'm not going to read to you, right from cardiac contractility to blood pressure to oxygen saturation, some of which have been validated, some of which are getting actively validated, alongside the one I just mentioned to you that you can also measure now NT-proBNP. This is being validated as we speak, where you can do a daily measurement of your NT-proBNP, just like you do continuous glucose monitoring using your smartphone over a continuous glucose monitor. That allows us to actually look after these patients. And beyond this, there are a slew of sophisticated sensors, and there are a slew of device data that can be used. And you can only imagine that now there's a lot of data, and the question you may come up with is, okay, this is interesting, but there's so much of data. Who's going to look at this data, and how are you going to interpret this data, and how are you going to put it together? This is where the role of artificial intelligence really comes into play. There's a beautiful saying by Daniel K. Morans who says, you can have data without information, but you cannot have information without data. So it is upon us to ensure that we can collect data, and that's where we need AI to help us collect, to curate, to annotate, to aggregate, and also analyze that data to provide us with the output that can then be integrated into our workflow that can help us manage patients. And there are places this is already happening, and we'll briefly talk about that. But I want you to understand, it's really interesting when we talk about data, there is this visible data that we see in our electronic medical records in the US for sure, and I'm sure many centers have that availability, which tells you about your demographics, your clinical covariates, your medications. But beyond that, there's this whole dark data, which is social, cultural, environmental, demographic data that exists below the surface that we don't know about, that contributes to 80% of disease. So only 20% of disease is actually dependent on the healthcare that we receive and what is visible to us. 80% is determined by what is below the surface out there. And much of that social, cultural, environmental data, I think we started recognizing it during COVID, how important it is, and it is now becoming a part and parcel of how we start thinking about patients. And I'm not going to belabor how the health data platform looks, but the health data platform has to take into account this data coming in from wearables and sensors, along with the other components, and be integrated into a health data platform that can allow AI to help us manage these patients. Now, this is a little bit of tongue-in-cheek, and this is largely because machine eyes are better than human eyes. We know that with AI because they recognize patterns. So everybody knows about analytic AI. So when I look at AI and I try to break it down, I look at analytic AI and generative AI. Analytic AI is the conventional ones that you all know about, machine learning, deep learning. It recognizes patterns and then helps prognosticate based off those patterns. It helps categorize and classify patients. The reason I'm showing you this is because the machine eyes can look at the retinal photographs, can look at the human eyes, and can actually categorize which patients are going to develop chronic kidney disease. They can categorize what your diabetes control is and whether you're going to develop diabetes. They can categorize what the severity of hypertension is and what your blood pressure level is, besides the fact they can also categorize whether you have coronary artery disease or not. All of the things that Paul actually had, right? Beyond that also, This is a homegrown algorithm at Mass General Hospital. It's called the Sybil algorithm, where you can look at the CT and you can see the solitary pulmonary nodules, which are oftentimes called as benign. But by looking at the nodule, you can predict which patient is going to develop cancer in 6 years from now or within 1 year from now. So that is already becoming possible through this pattern recognition and deep learning strategies that can be picked off these radiological images. Now, Paul had atrial fibrillation, so I think it's important for us to recognize what about atrial fibrillation. Now, when atrial fibrillation exists alongside with heart failure, I think all of us recognize it's called a double whammy. Patients do considerably much worse when they have these combinations out there. But now we know that AI-based strategies looking at ECGs can help us determine which patients are going to develop atrial fibrillation. It can help us determine which patients are going to develop sudden cardiac death. It can help us determine which patients are at a risk of a stroke just by pattern recognition of a 12-lead ECG. And there's considerable amount of data that exists out there. This is some work we've done, and this is based off a paper that was written in the UK where, again, it's resource constrained, so they can't look at AI ECGs immediately. So what they did was they looked at the EMR, the electronic medical record, did machine learning, and off that machine learning, were able to subcategorize patients as low, moderate, and high risk. And within those risks, they could decide which patients actually needed to have an ECG or which patients needed ECG-based further AI learning to determine who was at risk for atrial fibrillation or for stroke. This is work we've done with a patch monitor, looking at the first 24 hours of the patch monitor, and can pick up which patients are going to develop atrial fibrillation in the next 13 days with a reasonable AUC score, and this is getting refined much better, but it gives you an idea that the way you risk stratify patients is going to change quite a bit based off AI-based approaches. And then obviously some of the work we're doing, some of the work we did during COVID is we worked with the folks in France using watches, using a cloud-based AI algorithm to measure the watch ECG and measure the QT interval of the ECG so that these patients could be treated with, at that point in time, patients were getting azithromycin and hydroxychloroquine in France, so they needed to monitor the QT interval, so we used the watch to monitor the QT interval, and then obviously subsequently at Mass General, we're doing a QT interval monitoring study for patients who require to be loaded with drugs that cause QT interval prolongation in-house. We're concomitantly monitoring them with watches using a cloud-based algorithm to see if it actually works or not. So again, these are AI strategies that are not only being used through machine learning strategies for risk prediction, for risk categorization, for risk prediction, but also for managing patients and their therapy to give you an idea of what the flow and the integration of workflow will look like in the near future. Now, I want to share this data on an AI algorithm that was developed at Mass General to look at predicting atrial fibrillation in patients over a 5-year period. We looked at about 150,000 1.5 million ECGs, which are subcategorized, and then we looked at them and we created an algorithm by my colleagues, Steve Lubitz and Sean. But the important thing I'm trying to show you out here is that even though the algorithm was developed at Mass General, this was examined at the Brigham and Women's Hospital. So Mass General and Brigham and Women's Hospital are just 3 miles away, okay? The algorithm, interestingly, fared very differently at the Brigham than it did at Mass General. And why is that? The reason it's that is because the ethnic populations that receive care at Mass General are very different from those that receive care at the Brigham, even though they're just 3 miles away. And that's important. And that's important because algorithms that are created in the United States of America or in different parts of the US will not be applicable in India or will need to be tweaked because of the ethnic differences and the population differences in the data sets. And it becomes progressively important to recognize this. This is just to give you an idea of the disparity that exists in Boston, where I am from, I mean where I live right now. And if you look at this, if you look at within Boston, 8 miles apart, you have Boston Medical Center and Mass General Hospital. The number of black patients getting discharged from Mass General Hospital were just 5%. And you move a little distant to Boston Medical Center, and 40% of the patients getting discharged there are black patients. Now, the reason I'm showing this to you is that there's a disparity in how care is administered within different parts of the city, leave alone different parts of the country. We know that social and income inequality translates into how patients, what they eat, what their preventative services they receive, But these then get transmitted down into the genetic streams, and there's this whole effect called the weathering effect, where there's telomere shortening and other issues on immunity and issues on microbiomes that are affected by disparities in the digital divide. And the only point I really want to highlight out here is that there is the risk of digital divide with all these digital strategies, and we have to approach this in a very forward-thinking fashion and make sure we're not dealing with this later on. Now, I like to show this slide is because when I landed at Oxford, within the first few weeks, I was given this Holter monitor of a patient who had ventricular tachycardia and died with the Holter monitor on board, okay? So you can see the patient had 8 hours of an ECG strip and then landed up having a VT-VF arrest with the Holter monitor. And I was given that, and they said, figure out what happened and see if you can come up with a hypothesis. So I spent 16 hours a day for 16 weeks measuring every ECG interval to write one simple case report paper, trying to figure out what is the variability of heart rate variability, what is the variability of the QD interval, is there some hypothesis out here that can help us understand why this patient actually died. The reason I'm showing this is now, this is a paper that I just presented as a late breaker and at the Heart Rhythm Society last year. From the first 24 hours of a patch monitor, in 2 seconds, you can tell which patients are going to develop VT or VF in the next 13 days. Right? And this is all looking at AI-based pattern recognition of the heart rate plot, looking at the ECG using the CNN models as well as other forms of deep learning, and really putting these together. It just gives you an idea of how this will change, be a game changer in how we risk stratify patients and look after these patients in the future. And the AUC score is out here is 0.93, which is just phenomenal, that you can almost, with a 100% sensitivity and specificity, I'm exaggerating, but very close to that, predict which patients are going to develop VT-VF. So Paul had VT, as you know, and he also had atrial fibrillation. We talked about that, but he also got a cardiac resynchronization therapy device. And we know that there are now machine learning strategies that can subcategorize which patients may do well with machine learning, with phenogrouping out there. But these algorithms don't always work well. And if you look at the work from Mayo Clinic that looked at patients with CRT responders, and they said, let us look at some machine learning algorithms and develop some ensemble plots out here and see if we can predict which patients do well with CRT. And what did they find? Did not work at all. It did not work at all because the data they were using from computers did not truly represent all the information about that patient. So when we put a resynchronization lead in, we just say a lead was implanted on the lateral wall. We don't say what its proximity to the scar was. We don't say what its interaction with the activation wavefront was. We don't talk about the internal dimensions of the heart. We don't talk about what the extent of dysynchrony before and after is. All that information is missing from the electronic medical records. So even the world's best machine learning algorithm using electronic medical records cannot necessarily work well in all complex conditions. And that's something I think that's really important to kind of recognize out there. Now, I don't know if you can see this. Okay, so you can see this video out here. So this is, you can recognize me from my bald head out there. I'm doing an atrial fibrillation ablation. And what I'm doing out here is using augmented reality. And augmented reality is where you can actually create the holographic image of your cardio image, bring it up three-dimensionally up to you, and you can then move the catheters without a technician sitting outside and watching where the catheters are, and then in a very personalized way, ablate where you need to ablate. Okay, so we are able to use augmented reality, and now we're also using some advanced forms of AI, which there's a vector medical strategy that has been developed, which is created off 1 million simulations. But what we basically do is feed the ECG, a 12-lead ECG of an arrhythmia, into a computer, and it gives you the probabilistic source of where the arrhythmia is coming from. So you can actually go into a procedure knowing whether it's a left-sided arrhythmia or it's a right-sided arrhythmia, or how you want to characterize your day, how you're going to spend that day, but gives you an idea that AI is now being used for atrial fibrillation, not just in the management as we talked, the prediction, but also actively in the management of these patients, and it just needs to be finding a way into clinical practice. Hypertension, again, there are strategies to phenogroup hypertension. We know Paul was hypertensive, and there are wearables now that can actually measure which patients have ambulatory blood pressure monitoring on a beat-to-beat basis, and these are gradually getting validated. There have been a lot of issues with cuffless blood pressure monitoring, but now we have some validated strategies that are finding their way into practice. But again, they're not mainstream, but there are virtual strategies that people are using to monitor and manage hypertensives now at home. You do not have to come into the clinic to see your doctor. If you can take your blood pressure with a machine at home and virtually have an appointment and have an algorithm-based approach. So I'm going to come back to Paul. So what happened to Paul? So Paul actually did pretty well. His ejection fraction improved from 15 to 45 to 65%. So now he had no heart failure. What happened was, at the age of 75, he actually became a candidate for kidney transplant. An anonymous neighbor donated her kidney to Paul at 75. So Paul now, at the age of 76, was free of heart failure and was free of kidney failure. He actually became a dancing instructor at a senior center, okay? After he became a dancing instructor at a senior center, he actually found his wife, he got married to his wife, moved to Miami and started an antique business. And this is Paul, now 91 years old, okay? "20 years after someone had told him that he had less than 1 month to live." All right? So it goes to show you that many things went wrong out here, and the fact that chronic diseases were allowed to progress to renal and heart failure, all of which was actually preventable. We also know that care at that point in time, and to some extent even now, is very siloed and episodic. We're all competing with each other. We don't share our patients with other disciplines. We want to keep our patients to ourselves. We have to become multidisciplinary. But can you imagine that Paul lost almost 30 years of his life with renal failure and heart failure, going in and out of the hospital? Can you imagine the expense the system actually incurred because of him having renal and heart failure over these years? And that's the reason why we need to really be focused on fostering what I talked today is a digital culture. If we have to make medicine sustainable, if we have to see all the patients who are waiting outside in the outpatient and give them some degree of individualized attention, which we can't at this point in time, we have to create the right digital pathways. As much of a painful process it's going to be, the only way that healthcare will become sustainable is to create digital pathways. And creating digital pathways is very different from having digitized records. Creating digital pathways is changing the value proposition. It's recognizing that we have to move from this transactional care when we see our patients when they're ill or 6-monthly or 12-monthly. Illness doesn't happen at a 6-monthly or 12-monthly or a yearly basis. It can happen anytime. So creating digital strategies to help us provide continuous care that are assisted by AI-driven logic, much what we talked about, is the way we really need to look at care. Now, both Yash and Amit will agree with me that we've been implanting these devices for a long time. We used to see patients with these implanted devices on a monthly basis, then a 3-monthly basis. Now we follow them remotely. We practice what is called exception-based care. We see them every year or every 2 years because they have implanted devices that can transmit information to us remotely and wirelessly. We see them only on a yearly or 2-yearly basis, or what we call as an exception-based approach, or when they have a problem with their device, we bring them in. So that is changing the paradigm of care, and this is where remote monitoring really becomes important. I think the future of care, alongside the sensor-based strategy, requires remote monitoring, because remote monitoring is the only way that you can embrace the entire life cycle of disease. You can embrace the patient, whether they're in the outpatient, inpatient, office, wherever they may be, whether they're in the acute area. And this is where a synergistic convergence of both conventional AI, alongside generative AI, along with the sensors we talked with, but most importantly, alongside the clinician, is going to be important. And this is how we will treat chronic care, readmissions, and across a spectrum of cardiovascular disease. Some of this we're already doing at Mass General. We've already started actually doing a lot of home-based care. So acute post-procedurally, patients are sent home on the same day, and much of their care is now managed remotely through devices. Patients get pacemakers and go 2 hours after the pacemaker. They go home and they're monitored remotely alongside a lot of other clinical conditions that we do. Now, no talk would be complete if you're talking about AI and not mentioning ChatGPT, right? I think it's really important because we all talk about large language models, and large language models have their own issue. I think they have the risk of hallucinations and confabulations that we all know about. But I think the computational strategies are getting so refined that they're becoming now limited language models where they're trained on the right kind of information that they'll become more relevant. But what I really want to emphasize out here is that they're going to change the way patient and physician experience are. We have physician burnout, patients have a poor patient experience. We're already using now in an investigational way, I think we're 6 months away when this will get launched, we've just started using this, is ambient technology for keeping records. So when a patient walks into the clinic, I'm talking to the clinic, I can have a casual conversation with the patient, it all gets automatically transcribed into electronic record, into a note into the electronic record, which I can then edit in about a minute, minute and a half. This is called ambient technology, and this is generative AI at its play. We already have, so we have electronic medical records, we have patients that approach us through the physician-patient gateway, they send us email messages. Those messages are now taken care of by AI chatbots. There are responses which are more empathetic than responses from clinicians. And they are then edited by the nursing staff before they're responding back to patients. But that's happening. That's happening even in certain private sector out here in India, and I think it will eventually find its way into the way we manage patients on a daily basis. And then, obviously, generative AI, exactly with respect to what we talked about with Paul, has been shown now by some early work from NYU, some work that we're trying to replicate, that it actually predicts which patients are going to have hospital readmissions, and you can actually spend more time looking after them. But at the same time, you can also put into play self-management approaches, because no form of medicine is going to be sustainable if patients don't have any skin in the game, if patients don't become a part of the process of looking after themselves. Now, this is a thing that a lot of people fear. You know, as AI becomes a manifest thing, are there going to be certain disciplines that change? I mean, we know when the polio vaccine was developed, all the polio clinics disappeared. With anticoagulation clinics changing in the US, with DOACs, all the Coumadin clinics have disappeared. So similarly, there's a fear that the different disciplines within cardiology are going to change, or outside of cardiology are going to change. I'm using a cardiovascular example out here, but this is applicable across infectious diseases, neurology, kidney diseases, every possible subspecialty. But I want to share with you what a recent analysis has said, that almost 30 to 40% of job descriptions in the US in the next 7 to 10 years are going to change, and many of them will become AI and chatbot assisted, right? I mean, it's the only way forward. You can only imagine, right, the amount of expense in making a diagnosis and detailing what the clinical care pathway is going to look like is going to become zero with the use of AI-based approaches. And most of the expense will now be in the delivery of expensive medications and interventional strategies, but the diagnosis and the pathway is going to change the way in how reimbursement and how financing of these disorders is going to take place in the coming years, and that's something we need to be ready about. I'm very close to coming to the end. I think when we look at our practice in academic medical centers, I look at it in three particular pyramid scheme out here. I'm not going to talk about the top pyramid, but the upstream is where we spend a lot of time here at KEM Hospital looking after. We look after patients who are complicated, require surgical interventions, surgical procedures. And then we have the midstream care. We have midstream care, which looks after chronic disease management. It's wonderful to see Dr. Hema Kulkarni out here. It's an absolute pleasure. Can't be a bigger honor than that. So Hema was our HOD when I was training out here. Thank you, Hema. So coming back to when you look at care, there's upstream care, there's midstream care, and there's mainstream care. Unwell patients develop chronic disease. Chronic disease patients develop complications and require specialty care. So if you can attack the pyramid at the level of wellness through digital strategies, you will be reducing the number of chronic diseases. And if you can attack the patient of the midstream care with digital strategies that we talked about, like hypertension, atrial fibrillation, diabetes, you will actually reduce the burden of the upper segment of subspecialty care, and you will declutter a lot of the care that we see at KEM at many of the hospitals, where we don't have time to pay enough attention to our patients because of the different levels of care. So this, I'm going to go out on a limb out here, and I think this is really possible in India, and I think India has this unique ability to offset high margin care. And I think obviously the immediate components are creating an awareness and making sure that this is acceptable, but beyond that, also making it accessible. And we know accessibility is not an issue as much because smartphones are available and we can create technology embedded in these smartphones. And we know that this can also potentially become affordable. We know we have the intellectual power out here. No better power than the intellectual power here in India, for sure, 100%. It's uniquely poised for innovation. And you know, I can tell you as a brown-skinned man in the US, I feel very privileged to be brown-skinned because I'm automatically thought to be smarter than who I actually am. Okay? Now beyond that, I think innovation is really a central key out here that I think intellectual power will generate. And we can create these low-cost solutions. We can create low-cost solutions for education, which can work at the level of wellness. They can be disseminated through these digital tools. We can create these low-cost solutions for screening, diagnosis, and prevention. We don't even have to get into the high-tech interventional strategies that cost money. So the possibility of using low-cost medtech solutions to provide care is scalable. It's just a question of getting it together and getting our act together and making it happen. And a part of that is the awareness and the acceptability and the accessibility. So the future models of care are many, and I'm not going to belabor them. There are shared savings approaches. You know, medicine in the US, I think, is going to become a streaming service. Like you have cable network, and then you have Netflix and Hulu. I think you'll have streaming services for disease management models that will help us manage diabetes and hypertension because, you know, a heart failure doctor at Mass General, there's about 10 heart failure doctors. They manage 7,000 patients of heart failure that they follow up. It's impossible to ensure that those patients are not detuning and are developing heart failure. So that's where I think disease management models will come in. And I think self-management strategies are going to become key. So I'd like to conclude by saying that, you know, even though we talk about sensors and AI and reinvention of medicine, I think it's really important, this lovely saying that many of you probably have already heard, that the secret of the care of the patient lies in caring for the patient. And as much as care must always be personal, technology should always be tamed, and we should always continually strive to preserve the human touch. Thank you all for your kind attention.